Hi, this is Piyush Bhargava and you're watching the VQ Scan teaching file. Let's review the clinical imaging protocol for VQ studies. VQ Scan has two parts. V stands for ventilation and Q stands for perfusion. So the ventilation is typically performed first, where we use 30 millicuries of technetium-99m DTPA aerosol, and about 1 millicurie gets inside the patient into the lungs when they inhale using the aerosol apparatus. The common indication for doing a VQ scan is to evaluate patients for acute or chronic pulmonary embolism. With the advent of CTPE protocol, the study of choice for doing ruling out or ruling in pulmonary embolism is CTPE protocol, and for some reason if CT cannot be performed, that's when the patients get a VQ scan. After they inhale the aerosol, immediately after that we acquire 8 planar views of the lungs in different projections. These are standard projections: anterior, posterior, right lateral, left lateral, LPO, RPO, RAO, and LAO. The mechanism of uptake is alveolar deposition of technetium-99m DTPA aerosol particles. Physiologic distribution is seen in the lungs. If we wait for some time, we find that the particles are broken down and absorbed by the pulmonary capillaries and excreted from the kidneys into the urinary bladder. The critical organ is the lungs. After the ventilation study, we do the perfusion study, where patients are injected with 4 millicuries of technetium-99m MAA, or macroaggregated albumin particles, and immediately after injection we acquire planar images of the chest in same 8 planar projections. The mechanism of uptake is pulmonary embolism. So with these particles we are embolizing 0.1% or 1 in 1,000 pulmonary capillaries. Because it's a very low number of capillaries that are embolized, the embolism using technetium-99m MAA is not hemodynamically significant. Physiologic activity is seen in the lungs, and the critical organs are the lungs as well. Case number 1 is showing multiple images from a VQ scan with ventilation images on the top, the first row and the second row. The perfusion images are in the third and the fourth rows. The approach to reading a VQ scan is to compare ventilation to perfusion, and what I recommend is to first find the anterior view of ventilation, compare it to anterior view of perfusion, and see how well they match in terms of perfusion in the right lung, ventilation in the right lung, perfusion in the right lung, ventilation in the left lung, perfusion in the left lung. Then go to the posterior view and see how the ventilation matches with perfusion. So here they are well matched. We don't see any perfusion defects to suggest PE. This is either a low probability scan or a normal scan. In this situation, when there are no perfusion defects, then I recommend going to the RPO view of perfusion, comparing it to ventilation, and the LPO view of perfusion, comparing it to ventilation. In the posterior oblique views, most of the segments are well visualized, and normally we see a gradient of activity from below upwards or inferior to superior and from posterior to anterior, and those are the identifiers of a normal scan. So this is a normal VQ scan using technetium-99m DTPA and technetium-99m MAA. Now let's look at a normal VQ scan using xenon gas for ventilation. With xenon, the images are available only in the posterior projections, and these are different kinds of images such as first breath, equilibrium, and washout images. These are shown here on the top: multiple images from ventilation and a posterior projection using xenon. With perfusion, we are again using technetium-99m MAA, and we are comparing posterior view of perfusion to the posterior equilibrium image right here, and they match very well. There are no mismatched perfusion defects. Then like before, we look at the pattern of perfusion. We see normal gradient of activity in the left lung and also in the right lung. So this is a normal VQ scan using xenon gas and technetium-99m MAA. Here is another VQ scan using xenon, and we are comparing the posterior view here of perfusion to the equilibrium image here, and they match very well. There are no perfusion mismatched perfusion defects. The pattern of perfusion in the RPO view and the LPO view is normal. Here there's an interesting finding. As we go through the images into the washout images using xenon, there is activity seen in the liver. Xenon is fat soluble and is taken up in the liver, which is seen here. Also, the washout images are very sensitive for areas of air trapping from COPD. Case number 4 shows a VQ scan in a patient with severe COPD, where when we start looking at the ventilation in the anterior image, comparing it to perfusion, and then ventilation in the posterior image, comparing it to perfusion, we find that overall the pattern of perfusion is more uniform compared to patchy and heterogeneous ventilation with central deposition in the airways from turbulence secondary to COPD, and patchy ventilation also secondary to COPD. So when patients have severe COPD, ventilation is worse compared to perfusion. This is a low probability scan for PE. There is also redistribution of perfusion where there is a loss of gradient from below upwards and posterior to anterior, and most of the perfusion here in the left lung and here in the right lung is in the superior and anterior pulmonary segments. Case number 5 is showing another VQ scan where when we compare anterior of ventilation to anterior of perfusion, we find that this part of the lung is where perfusion is missing, but it is getting ventilated. So there's a mismatched perfusion defect. It's better seen here in the posterior view of ventilation where there is ventilation, but there is no perfusion. When there are mismatched defects, then again we go back to the posterior oblique views, especially here in the right lung, to see which segments are involved. So when we compare this image to this image of ventilation, we find that posterior basal, lateral basal, and anterior basal segments, 3 segments do not show any perfusion, but they are getting ventilated. And when there are 2 or more mismatched segmental perfusion defects, the probability for PE is high. So this is a high probability scan for acute pulmonary embolism. Next case, anterior of ventilation, anterior of perfusion, posterior of ventilation, posterior of perfusion. Now here it almost seems like this part of the left lower lobe is missing in ventilation and perfusion. But if you look at the pattern, it seems like there is enlargement of cardiac silhouette. And when we look at the posterior oblique view in the left, we find that this is a normal contour of the diaphragm, which is pretty high, and then there is no activity below that on the perfusion and also on the ventilation. So this is a matched defect from an enlarged cardiac silhouette. The scan is low probability for PE. Case number 7, anterior of ventilation, anterior of perfusion, posterior of ventilation, posterior of perfusion, very well matched, no mismatched perfusion defects. But look at the costophrenic angles, these are blunted. On the earlier images, the costophrenic angles were sharp. This patient had bilateral small pleural effusions seen as small matched defects. Now when we look at the posterior oblique and compare LPO perfusion to LPO of ventilation, we find that there is redistribution of perfusion superiorly and anteriorly in a matched fashion. Similarly, in the other lung, the right lung, there is redistribution of perfusion anteriorly and superiorly compared to ventilation. The scan is low probability for PE. Case number 8, ventilation, perfusion, ventilation in the posterior view, and perfusion. Now here in both lungs, there are characteristic wedge-shaped, pleural-based, mismatched perfusion defects here in the left lung and also right here in the right lung. And what we do next is we look at the posterior oblique view here on the right and here on the left, try to identify which segments are involved. So here in the right lung, apical, anterior, and posterior segments are mismatched, which are ventilated but not perfused. Posterior basal is mismatched, lateral basal and anterior basal look okay. You should be familiar with the line diagram of segmental annotation on posterior oblique views in both right lung and left lung to identify which segments are involved and to say if one or more segments are mismatched, and then based on that give it a probability. 1 moderate size to 2 large mismatched perfusion defects are classified as moderate or intermediate probability for PE, and anything less than 1 moderate is classified as low probability for PE. Another high probability VQ scan using xenon. Here is the equilibrium image which we compare to posterior of ventilation. Here you can see in the right lower lung zone there are several segments which are not perfused but they are ventilated. So several mismatched perfusion defects there and another mismatched perfusion defect here in the right upper lung zone. We go to the posterior oblique view right here in the right lung and here in the left lung to identify which segments are involved. Apical, anterior are okay. Posterior segment of the right upper lobe is involved. Posterior basal is okay, lateral basal is okay, anterior basal is involved, and probably the lateral segment of the right middle lobe is also involved. So this is a high probability scan for PE. Case number 12, Here we look at ventilation, compare it to perfusion, ventilation, perfusion. Overall, the pattern of perfusion is better than ventilation. Pattern of perfusion here is better than ventilation. So a low probability scan for PE. You want to confirm the same finding on the posterior oblique views. RPO, LPO, RPO ventilation compared to perfusion. Perfusion is much better. And here LPO perfusion compared to ventilation. Perfusion is slightly better. So a low probability scan for PE and likely severe COPD. We also see central deposition from turbulence. Case number 11 is showing a high probability scan. Look at the ventilation image in anterior projection, perfusion image in the anterior projection, ventilation image in the posterior projection, perfusion image in the posterior projection. There are bilaterally mismatched segmental perfusion defects consistent with acute pulmonary embolism. Case number 12, this is an interesting case. We did the ventilation and we did the perfusion. We thought they were matched, but the pattern seems very unique where there is almost no difference between ventilation and perfusion. And what happened here was the entire dose of technetium-99m MA was infiltrated and nothing went into the patient. So the images that were acquired and labeled as perfusion were actually looking at ventilatory activity. And I was telling you before, the DTPA particles are broken down in the lungs and they're absorbed and excreted from the kidneys into the bladder, and that's what we see here. And the perfusion injection was repeated and then the scan was reported, which is seen here. So ventilation is the same. Now look at the pattern of perfusion with a good injection. The perfusion looks better than ventilation and it turned out to be a low probability scan. Case number 13, another high probability scan. Look at ventilation anterior image, perfusion anterior image, ventilation posterior image, perfusion posterior image. Here the entire right upper lung zone shows absent perfusion compared to ventilation. When we look at the posterior oblique view, we find that apical, anterior and posterior, all three segments of right upper lobe do not show any perfusion compared to ventilation. So right away it's a high probability scan for PE. Another interesting study, case number 14, we have ventilation image in the anterior projection, perfusion in the anterior projection, ventilation in the posterior projection, perfusion in the posterior projection. And just looking at these and comparing them, there is diffusely decreased perfusion in the right lung in the anterior image, diffusely decreased perfusion in the right lung on the posterior image. Also, the ventilation is not normal either. Now, over a period of time, when there is acute PE and there is no blood going into a lung, body's compensatory mechanisms come into play, and there is a regulation of the airways in such a way that more ventilation is sent to the other well-perfused lung rather than the lung with deficient perfusion. So that is the reason why the ventilation is abnormal here. But since the perfusion abnormality is more severe, this patient had a saddle-shaped embolus sitting in the right pulmonary artery, causing diffusely reduced perfusion to the entire lung, and that's the reason we see this asymmetry between more severely reduced perfusion in the right lung compared to ventilation. Case number 15 is another interesting case with a interesting cause of decreased perfusion in one of the lungs. Patient presented with a chest x-ray, 55-year-old male with 40 pack year smoking history, and an abnormal chest x-ray which shows a mass here in the left lung. And here is a CT showing the mass and some lymphadenopathy, not very well seen in the lung windows. So let's look at some more images in this patient. Here is a CT image and the correlative PET CT image. Let's look at the whole body image first, where here is the focal hypermetabolism in the left lung, primary lung cancer, and there is a large focus in the left hilum consistent with hypermetabolic mediastinal lymphadenopathy. Now these two images are from the CT without contrast and the FDG PET at another level where we are seeing the left main stem bronchus and at the same level showing hypermetabolism in hilar lymphadenopathy. Now at this level where we are looking at the left pulmonary artery, look at how narrow the pulmonary artery is due to the effect of surrounding hypermetabolic lymphadenopathy. So lymphadenopathy is narrowing the left pulmonary artery, and because of which this is the pattern that we see on their perfusion, where the left lung looks okay in the posterior view. Here's the anterior image, so here is the left lung, here's the posterior image, so here is the left lung. Left lung shows diffusely decreased perfusion when compared to the right lung. And look at the posterior oblique view, how diffusely the perfusion is reduced in the left lung due to this hypermetabolic lymphadenopathy from lung cancer. So those are some of the patterns that you may encounter when you are reading a VQ scan. Thanks for watching.